Act 2 of structure and function of the cardiac system. All right. So we have now finished our discussion regarding structure and sort of where things are speaking. But now we're going to talk about the actual sort of mechanics of the flow of blood through the heart. So the conduction system of the heart. The conduction system has specialized cells that actually enable it, and when I say it, I mean the heart, to sort of generate and transmit action potentials without stimulation from the nervous system. So remember at the very, very, very beginning of the semester when we talked about action potentials of the cells and the sodium and potassium switching places along that cell membrane. Again, I was not just talking about it because I like to talk about it, because I don't. I'm talking about it because it really does make a difference, and this is exactly why. In the heart, and heart cells, and in nerve cells. And it just so happens today that we're talking about heart cells. So that continuous rhythmic repetition of those atriums and ventricles beating in, harmony with each other depends on the transmission of those electrical impulses, of that action potential that we talked about on, I think, day 1, right, of the semester. So cardiac action potentials. This happens so much so, and I know it's kind of hard to believe, but I just said it and I'll say it again. This happens so much so in the heart that it doesn't even need innervation from the nervous system. The heart can do this on its own. And to sort of illustrate that, the heart can actually beat under the right circumstances outside of the body. Just because its own cells in isolation with itself can transmit action potentials from place to place within that tissue, within that myocardium. Pretty phenomenal, if you ask me. Okay, so how does it do that? The myocardium has its own conduction system. How does it do that? It does it through sort of these series of nodes that are placed strategically throughout the myocardium, right? So let's talk a little bit about those nodes. The first one, and sort of perhaps the most important one, if you will, is the sinoatrial node. And it's also known as the pacemaker of the heart. It lies, as you see here on the screen, at the junction of the right atrium and the superior vena cava. So it's like right here, right? This big black dot right here is sort of the SA node, okay? That's where it's located. It's where the impulse for the heart to contract begins. That's also why it's called the pacemaker. It makes the pace for the heart. And under normal circumstances, under normal healthy circumstances, not only is it where the impulse begins, it controls the sort of rate of depolarization at about a rate of 60 to 100 beats per minute. Sounds familiar? What's that? What's 60 to 100 beats a minute? The normal heart rate. Exactly. So our normal heart rate comes from the fact that the SA node causes depolarization at a rate of 60 to 100 beats per minute. Now, the node down the chain of command, if you will, the next node is atrioventricular node. And it, just as the name might suggest, is in the right atrial wall, superior to the tricuspid valve. So like right in here. Again, here's my big black sort of circle here showing where this may be. Okay? Right here, atrioventricular node. As I mentioned here on the screen, it's pretty well situated for mediating conduction between the atrium and the ventricle. Obviously, between the right atrium and the right ventricle. But also, it's pretty darn close here to the septal wall as well. So it can very easily jump from here to the septal wall and be able to sort of feed the rest of the heart via the conduction system. So well situated for mediating conduction between the atrium and the ventricle, but also to the left side of the heart as well. Now, should something happen to the SA node, let's say someone had an MI, right? And it just so happened to cut off blood supply to the part of the myocardium where the sinoatrial node is and wipes out the pacemaker of the heart, wipes out that node. Luckily, the atrioventricular node can sort of take over as the pacemaker of the heart, so the heart will not stop beating just because the SA node's been damaged or wiped out. However, look at the sort of intrinsic rate of conduction of the atrioventricular node, 40 to 60 beats per minute. So the heart's still beating, but now we're looking at a patient, let's say, like I said, if the SA node's been damaged, now we're looking at a patient who is pretty significantly what? Bradycardic. Right, exactly. So yes, the heart's still beating, but if the atrioventricular node is the one taking over the conduction system of the heart, this person's going to be pretty significantly bradycardic and probably symptomatic. What would be some symptoms of profound bradycardia that this patient coming in who has now wiped out their SA node might look like? Confused. So change of level of consciousness. Huh? Low blood pressure. Good, because you're not beating as much blood out of the heart, so therefore not enough blood to the whole system. And that's why the person would have a change in level of consciousness, because you're not getting enough blood to the brain. Good, good. So those kinds of things. Good. All right. So now the AV node is here, right? And as I mentioned, it can quite easily transmit conduction to the septal membrane. So the next place that the conduction goes is to the bundle of His, or what we call the AV bundle. That is sort of right here within the septum. Imagine that. What a great position for it to be in, right? Here's the bundle of His. Conducting fibers of the AV node converge across here to form the bundle of His within the septal wall. Okay? So there's the bundle of His. Now the bundle of His gives rise to what we call the right and the left bundle branches. And what those basically are, are these branches that come down here now and feed the right side of the heart and the left side of the heart in terms of, electrical impulses, right? Before we leave this slide, going back up to the sinoatrial node for a moment, as I mentioned, its rate of depolarization is 60 to 100 beats per minute. That's our normal heart rate. What's another term we use for a normal heart rate? Anyone know? Normal sinus rhythm. Exactly. Sinus rhythm coming from that sinoatrial node. Good. Okay, just want to make sure I drove that point home. Okay, now, going back to the bundle of His. Sorry. All right. From the bundle of His, as I mentioned, it branches off into the right and the left bundle branches. And these bundle branches are what travel down into the apices, so these lower sort of deep south parts of the ventricles, respectively, both the right and the left side. Then even from the bundle branches, they branch off even more into these little tiny fibers called Purkinje fibers, right? So all these little bitty little fibers that branch off and feed the rest of the ventricle. So Purkinje fibers are the terminal branches of the right bundle branch and the left bundle branch. That's what RBB and LBB is. They are an extensive network that promotes that rapid spread of impulse down here into the ventricles. Now, let's say someone has a really extensive MI, and they wipe out their sinoatrial node and they wipe out their AV node. The Purkinje fibers also have a spontaneous intrinsic rate. But look at that rate, 30 to 40 beats a minute. So now we're talking about someone who's got profound bradycardia. This person might be unconscious. I mean, this person, may not even be mentating at all because of the lack of cardiac output and the lack of blood circulating to the system. Yeah. When the sinoatrial node is working properly, they're just kind of in conjunction with that 60 to 100. So I wouldn't say they're dormant, but they're just kind of listening and sort of getting their message from the sinoatrial node to sort of beat appropriately. Is it doing 30 to 40 beats a minute while our SA node is? No, really, I guess the way to think of it is that if you were asking these things to be the pacemaker, that's what the rate would be. Under normal circumstances, they're just listening and helping the sinoatrial node beat at that 60 to 100. Does that answer your question? It's if you're asking them to be the pacemaker, that's what they're capable of. Does that sort of answer your question? Okay. All right. Okay, good. So, in summary, these nodes sort of keep the conduction of the heart going in an organized, sequential, efficient manner, right? The SA node talks to the the AV node talks to the bundle of His talks to the bundle branches and the Purkinje fibers, and then you start over again, right? That's the sort of flow of the electrical impulse, of the conduction system, every single beat, right? SA, AV, bundle of His, bundle of branch, Purkinje. SA, AV, bundle of His, bundle branch, Purkinje. That's what happens every cardiac cycle. Now, when in terms of like wiping one of these nodes out, then it would sort of skip that node that I talked about. But this is what happens every single beat. So an organized, sequential manner, known as the electrical activity that occurs through the myocardium each cardiac cycle, is known as normal sinus rhythm. Okay? This flow from node to node to node to node is normal sinus rhythm. When we talk about the beats per minute that each node could be responsible for, like you were just talking about, we're talking about a term called rhythmicity, okay? Rhythmicity. So, again, the beats per minute that each node could be responsible for, if you ask them to, is called rhythmicity. Now, there's another term besides rhythmicity that I want you to be aware of, and that is automaticity. That's different. Automaticity is when we talk about the property of generating spontaneous depolarization and action potentials without a stimulus from the nervous system. Again, I'll say that again, but that's automaticity. Automaticity is the ability or the property of generating spontaneous depolarization or action potentials without stimulation from the nervous system. So automaticity, it's able to do it automatically without the nervous system. Does the definition of rhythmicity and automaticity make sense to you? Okay, yeah. Rhythmicity. The rhythmicity is what we talked about when we talked about the beats per minute that each node could be responsible for. So like, Purkinje fibers being 30 to 40. Atrioventricular node being 40 to 60. That's what I'm talking about. That's basically the rhythmicity that I'm talking about. Okay? Automaticity just means is the ability for the heart to sort of conduct electrical activity without the nervous system. That's automaticity. Okay. All right. And here again, not that I'm saying my lovely illustration up here on the board is not sophisticated, but this is a little bit better for you, right? So here's, again, that visualization of here's the sinoatrial node. It conducts through several different fibers to the AV node, which conducts through several different fibers to the bundle of His, which conducts down into the bundle branches and out into the little Purkinje fibers. Okay? Any questions about conduction? Okay. So moving forward, the node's ability to electrically activate the muscle cells and actually make the muscle contract and to do something is depolarization, right? I mean, we talked about that already at the beginning of the semester, but that is truly what depolarization is. Depolarization is the movement of electrically charged ions, again, that potassium and sodium, across the cardiac cell membrane, which actually creates the electrical activity, which creates that action potential. And when I say that, when I'm talking about the depolarization electrically speaking, what am I talking about mechanically speaking? What happens mechanically at the time that the electrical aspect of the heart is depolarizing? What's happening to the muscle? Contraction, right. And then how about repolarization? So repolarization is the deactivation of the electrical activity. So what's happening to the cardiac muscle then? Relaxation, right. And then you have this sort of in-between zone called the refractory period, which is really sort of the regrouping of the heart. It's the period in which there really is no new cardiac action potentials occurring. There really is no electrical activity occurring. And you can't really it really can't be stimulated at that very sort of brief moment of that refractory period because it's sort of regrouping for that next electrical activity. It follows depolarization. So, again, here's the textbook explanation. Here's the classroom sitting in your chair explanation. What does this look like clinically? What can we see? What can we do? What test can we do on a patient at the bedside to sort of look at the sum of all the cardiac action potentials that's occurring in this person's heart? What do? An EKG. Clinically, what this is an EKG, right? So the sum of all cardiac action potential activity can be captured clinically with our patients at the bedside by an electrocardiogram, an EKG, or an ECG. Okay. Who's familiar with the electrical waves and the sort of electrical, how that looks? So who's familiar with an EKG and what each thing means? Yeah? Some? Would you like to review it? Okay. I think I'm running out of room on the board, so let me do it over here. Okay. Now again, this I want you to be clear about, because I'm going to talk about sort of the perfect world today, what a normal, healthy EKG wave should look like. Next week, on Monday, we're going to talk about what it may look like under alterations, right? So changes in an EKG because of an MI, let's say, or ischemia, okay? But here's a normal EKG for baseline levels today, and I'm so sorry that there's not better board space here. Okay, sorry. No, you're fine. You're fine. Okay, so first thing you have is this isoelectric line. So here's my dashed line right here for you, okay? This is the line, the isoelectric line, meaning no electrical activity, that all depolarization and electrical activity stems off of, right? So the first thing you see on an EKG is a, what's this called? P wave. Electrically, what does that symbolize? What's going on during a P wave? Atrial depolarization, atrial contraction. Good. Okay, so you've got your P wave. Then you've got your QRS complex. Actually, I'm going to make that a lot smaller. What's the QRS complex represent? So this is QRS. Ventricular contraction. Good. Or ventricular depolarization. Then you have this. What's this called? T wave. What does the T wave symbolize? Ventricular repolarization. Okay? So you've got depolarization of the ventricles and then the electrical repolarization of the ventricles. Depolarization of the atrium. Is there no repolarization of the atrium? Where is it? Yeah, it's a very small electrical sort of wave as compared to this huge QRS complex. So it's here. It's just the QRS is sort of so much larger that it sort of superimposes itself on top of the P wave, and or on top of the repolarization of the P wave, and you can't really see it, but it is there. So P, atrial contraction; QRS, ventricle contraction; T, repolarization of the ventricle. That's a normal. That's a normal EKG. If you see this 60 to 100 times a minute, that's normal sinus rhythm. Yeah. QRS. Is that what you mean? Here? Yeah. So here's, oh, I see what you mean. You know what I'm doing? I'm getting ahead of myself. I'm doing a MI. Sorry, guys. That's next week. Can you tell how pathologically and dark as a nurse I think that, like, I just assume this person's having an MI? I'm sorry. Thank you. Q. Is that terrible? QRS. Okay? Sorry. We'll talk about that next week. Yeah, but that's important, and I'm glad you pointed that out, because this, with it going up or down, is going to be a big part of our discussion next week. So thank you for bringing that to my attention. I'm sorry. QRS. Okay. It's that worst case scenario skeptical ER nurse that I am. All right. So QR, let me erase this so you don't get confused. S. That happens 60 to 100 times a minute, and that's normal sinus rhythm. Okay? Does that make sense? Okay. Thank you for correcting me. All right. And again, here's a better sort of vision for you. Any questions about the electrical activity or conduction of the heart? Clear? Okay. So now, in continuing to talk about the structures that control the conduction of that electrical activity throughout the heart, we have to talk a little bit about, okay, now I'm going to sort of contradict myself, but I'm not going to contradict myself. we have to talk a little bit about the cardiac innervation and the cardiac stimulation that the heart receives from the autonomic nervous system. Now, I'm truly not contradicting myself because the heart does have its own automaticity. The sinoatrial node does have its own rhythm that it can do by itself without communication from the nervous system. However, may there be times in our lives that we need our heart to beat faster than 60 to 100 times a minute. Yeah, right. Perhaps during fight or flight, when we're running from a mugger, as I gave you the example before. Perhaps when we're exercising, right? We're on the treadmill. You're going to feel pretty crappy if you're trying to run and you're trying to exert more energy and your heart's only beating at 60 to 100 times a minute. You're going to feel pretty lightheaded. You're going to pass out. So your heart needs to be able to be able to sort of increase at certain times in your life. So it's the autonomic nervous system that helps us do that, right? It can control the rate of impulse generation. It can control the rate of depolarization and repolarization. And it can actually increase or decrease, if need be, the strength of contraction. So the autonomic nervous system can actually help with contractile force and help with how fast the heart's beating. Again, in times when you need to. Like when you're on the treadmill, like when you're running, like when perhaps even you're just nervous. You're standing up and going to be giving a public speaking to a bunch of people. Your autonomic nervous system is going to kick in. And it can either kick in sympathetically or it kicks in parasympathetically. If the sympathetic nervous system is what's being sort of called upon, what's going to happen to your heart? What's going to happen to the conduction? What's going to happen to the activity of your heart if the sympathetic nervous system has kicked in? Fight or flight kind of stuff, right? So it enhances the myocardial contractility. Again, if I'm running for my life from someone who's attacking me, right? I'm hoping that my myocardial contractility increases to pump more blood up and out of the heart, right? It's going to increase my heart rate. And it's going to hopefully increase venous return, meaning increasing how fast the veins are bringing blood back up into my heart to be pumped out again, right? If I'm in need of increased physical activity, I'm hoping my heart can compensate and pump faster and pump harder, right? What about after I get done exercising or after I have escaped my mugger? I don't know why I keep using that example. What do I need my heart rate to do? I need my parasympathetic nervous system to kick in. I need it to decrease my heart rate. I need it to slow that conduction through those nodes, specifically through the atrioventricular node. I need it to sort of dilate those coronary arteries and get blood back to my heart and kind of reset the system, right? So sympathetic, the way I want you to remember it, sympathetic nervous system is going to ramp up the activity of the heart during times of fight or flight. Parasympathetic nervous system is going to sort of make that heart calm down again, decrease the heart rate, decrease the contractility during times of need of rest and repose, so to speak. Does that make sense? I'm not contradicting myself that the heart doesn't need the nervous system, but in times where we need the heart to do more than what that automaticity does, we need the autonomic nervous system to do one of the two accordingly. Does that make sense? Okay. All right. Last but not least, before we start talking about sort of cardiac output and how much blood gets pumped out of the heart. Last but not least, myocardial contraction and relaxation. Okay. Myocardial muscle is pretty identical, pretty similar to skeletal muscle cells. Now, we haven't talked about the skeletal system yet, so we haven't done a lot of discussion regarding sort of actin and myosin filaments that allow for sort of coupling and then contraction and relaxation of muscles. We will next semester. But today I'm going to give you the sort of quick and dirty so that you can understand the actual sort of contraction, relaxation of the muscles themselves. So very identical to skeletal muscle cells. And the reason that it is because of this relationship between actin and myosin. Okay, who remembers anything about actin and myosin filaments and fibers in muscle? Yeah? Okay, great. So everyone was wondering, what the heck is she drawing whenever I was drawing this lovely picture up here on the board? And now I'm going to tell you. Okay, so this little sort of like pearl kind of helix looking thing here are the actin filaments in our muscles. And my black marker is running out. Actin. And then what's this down here, this sort of golf club looking thing? Myosin. Good. All right. Now, what I truly want you to understand is that, obviously there's a bunch of these actin filaments and there's a bunch of these myosin filaments in a muscle. They have to be able to sort of couple with each other and attach to each other and pull themselves in to each other to be able to create a muscle contraction. Then when it relaxes, those actin and myosin filaments release from each other and are able to sort of slide out and pull apart. So they couple, contract, release, relax. Okay? And they sort of grab each other right here at this actin-myosin binding site to allow for that coupling and that pulling in for contraction. However, anyone remember, can they just spontaneously, whenever they want, be able to sort of couple here and pull themselves in? What has to happen? Right. So here at this binding site, there is something called tropomyosin at the binding site, a tropomyosin binding site. And I'm sorry, my marker is running out. Okay? That blocks the ability for actin and myosin to couple and hold on to each other and pull each other in. So there's a lock, essentially, on this binding site that prohibits actin and myosin from coupling and contracting. And that's good, right? Or else we'd constantly be in a state of muscle contraction. That doesn't sound very pleasant to me. So it's good that that site is blocked. How do we unblock it? How do we get that tropomyosin to move off that binding site so that actin and myosin can couple to contract? How do we get that off of there? ATP, so this is definitely a very energy-needing process. Very good. Anyone know? What else? Calcium. So over here we have another site called troponin that needs calcium to bind to the troponin, which then talks to the tropomyosin site to release and allow for actin and myosin to couple and start to contract. So the relationship between actin-myosin coupling and association with calcium, troponin, tropomyosin complex is crucial for proper contraction. We need calcium, and we need it to bind to the troponin to release the tropomyosin and allow for binding. Okay? Now, again, let me make it clinically relevant to you. So troponin and this sort of complex is ever present in skeletal muscle, but also in cardiac muscle. Troponin molecules are released into the bloodstream when there is myocardial muscle damage. When there's been a lack of oxygen and a lack of nutrients to the myocardial muscle, to this site, basically, in the cardiac muscle, troponin is actually released. When this part of the muscle is damaged, troponin gets released out into the blood system. So clinically speaking, if I'm an ER nurse taking care of a patient who's coming in with chest pain in the ER, and we draw troponin, and it's elevated in the blood, what does that tell me about the cardiac muscle? There's been some sort of damage. There's been some sort of lack of blood flow, lack of oxygen, lack of nutrients, getting to that muscle for it to release troponin. Cardiac muscle does not release troponin if it's not damaged. So if you see an elevated troponin in the blood, you basically know right there that you're probably having an MI. Because the cardiac muscle has been damaged and is releasing that troponin. And therefore, cardiac muscle contraction is going to be altered, right? Because you don't have that troponin to talk to tropomyosin to create that normal contraction. Okay, make sense? Here's just a little review for you. So here's my little my actin, my myosin, and where the calcium would sit there to sort of either attach to the troponin and then move the tropomyosin, or in times of alteration, not. Yeah? No. Good question. Troponin is usually a very specific to cardiac muscle. There are other things like CKMB, like other other things that get released when other muscles been damaged, but this is specific to cardiac. Yeah, good question. Very good question. All right. Any questions about that? Okay. Last but not least, cardiac output. So all of these things that we've talked about today, be it structure, be it conduction, be it nervous system stimulation, be it muscle activity, all of these are super important, but they're more on sort of a micro level. We're looking at the muscle, we're looking at the electrical activity, we're looking at the structures. Now we're taking sort of a step back and looking at the big picture of how the heart actually outputs blood, how it actually ejects blood out of the heart. Okay? So cardiac output. Anyone familiar with this term? Talked about this term before? Okay. Cardiac output is the volume of blood flowing through either the systemic or the pulmonary circuit, so either the right side of the heart or the left side of the heart, in liters per minute. So obviously this depends on body size, it depends on activity level, it depends on someone's physical fitness level, so to speak. And by that I mean, my normal cardiac output sitting in a chair is going to be much different than, a marathon runner or Lance Armstrong or someone like that, which is also going to be very different from my 85-year-old grandmother, right? So cardiac output really does depend on a lot of factors like body size, activity level, et cetera, et cetera. This is the concept of cardiac output is extremely important to our practice. I really want you to understand this. I really want you to have a good grasp on this, and I want you to understand the factors that impact it, the factors that affect it, because this is where we start to see symptoms. This is where we start to see symptomatology in our patients, okay? So the volume of blood that gets pumped out of the heart every minute is what cardiac output is. There's a formula for it, as you guys are probably aware, and that is cardiac output equals heart rate times stroke volume. And again, I hope that makes sense to you, because the amount of blood being pumped out of the heart to the body depends on how fast the heart is beating and how much volume the heart is actually able to beat out, right? That's what cardiac output is. It's the relationship and the combination of how well the heart's beating and how fast the heart's beating. That's cardiac output. Now, clinically speaking, there are things that impact that for our patients. So obviously stroke volume and heart rate impact cardiac output, but look at each one. Look at stroke volume. Look what affects it. Concepts called preload and afterload, which we're going to talk about, and contractility. Both of these things affect someone's stroke volume. And the thing that impacts someone's heart rate is our autonomic nervous system. We just talked about that, right? Either sympathetically increases it or parasympathetically decreases the heart rate. So any of these things could certainly, therefore, sort of indirectly, through this chain of command, end up impacting cardiac output, end up impacting how much blood that person is beating out of their heart. So again, really want you to understand this. So many of our cardiac patients' issues stem off of one of these things, whatever it may be on the screen, going wonky, right? And if one of those things gets messed up, it all is going to start impacting someone's cardiac output, okay? And again, when we're talking about cardiac output and we have decreased cardiac output for one reason or another, what kind of symptoms do we see in our patients? Change in mental status, like you talked about, low blood pressure, decreased circulation to the periphery, so to our fingers, toes, legs, other organs, etc. That's why we care. If we have low cardiac output, we're going to have low blood volume to our kidneys, to our brain, to our liver. Things are going to start going south really fast for people who have, for some reason, decreased cardiac output. Okay. So let's talk a little bit about factors that affect cardiac output specifically and individually. So the first thing I told you that impacts cardiac output is stroke volume. How do we measure stroke volume? We look at the end diastolic volume, so the blood in the ventricle at the end of relaxation, and we subtract the amount of blood that's in the ventricle at the end of systolic phase, right? So that should make sense. You subtract the amount of blood that gets pumped out from the amount of blood that was there to start with, right? That should tell you how much blood gets pumped out during each stroke, during each contraction. Is we had all this blood in the ventricle, how much of that blood in the ventricle actually got pumped out, right? That's your stroke volume. Stroke volume is impacted by two things: preload or afterload. Now, I remember whenever I was learning about this in my patho course, I was like, what? Let me try to bring it back to you a little bit here. Okay. So again, all I want you to understand is that stroke volume is the amount of blood being forced out of how much blood got forced out of the ventricle during contraction. Do you understand that? Okay. There are some things that impact stroke volume. Just like stroke volume impacts cardiac output, preload and afterload impact stroke volume. Let's talk about what these things are. When I say the term preload to you, I want you to think, anytime you hear the word preload, I want you to automatically think volume of blood. So preload is the amount of blood and we're going to specifically talk about the left side of the heart when we're talking about this, okay? So the left ventricle. Preload is the amount of blood or the volume of blood in the ventricle at the end of diastole, at the end of contraction, or at the end of relaxation, okay? So basically, in other words, how much blood is in the ventricle at the end of diastole? That's the preload, okay? How much blood is sitting in the left ventricle at the end of filling, at the end of diastole, at the end of relaxation? Depending on how much blood is in the ventricle at the end of relaxation, determines how hard the ventricle then, when it contracts, can contract. And this is how I want to bring it sort of more understandable to you. This happens due to something called Frank-Starling law of the heart. This is how I can think about it. Think about a rubber band. You've got a rubber band in your hand. Think about the harder you pull back on that rubber band, when you release it, the harder it snaps back, right? Same thing in the left ventricle. The more you fill that ventricle, the more when you're ejecting the blood out, the more you stretch that ventricle with blood, the harder it's going to contract back, right? So if you really fill that left ventricle, it's really going to snap and contract. If you have this little bitty amount of blood that fills the left ventricle, it's going to go when it contracts, okay? So it's just like a rubber band. Pull it back hard, it's going to contract hard, right? Fill the ventricle, it's going to contract hard. That's Frank-Starling law of the heart. So do we want the ventricle to have a nice, good volume of blood in it before it contracts? Yeah, because it's going to make contraction that much better. If it's nice and full and really pulling on the walls of the ventricle, it's going to contract that much better. Now, keep that in mind, though, because the harder, like I said, the harder you pull back, the harder it snaps. But, in the analogy of the rubber band, can you overstretch a rubber band? Yeah. If you keep doing that and keep overstretching it and overstretching it and overstretching it and overstretching it, when you let go, what's going to happen? It's going to be all stretched out, right? So if you've got too much volume in the ventricle, it can overstretch the ventricle and it's not going to properly contract. So either way, too much blood or not enough blood in the ventricle can impact preload. So we want this sweet spot. There's this sweet spot of volume right in the middle that you want to be able to fill the ventricle with so it has that nice, proper, optimum contraction. Does that make sense? That's preload. The volume in the ventricle that stretches the ventricle wall prior to contraction is preload. Can you imagine now how if that volume was altered for some reason, either too high or too low, it can end up impacting stroke volume? Yeah, okay. So that's one thing. That's one thing that impacts stroke volume. The other one is afterload. And so now when I say afterload, I want you to think pressure, okay? Preload is volume, afterload is pressure. And what I mean by that is afterload is the pressure that the heart must overcome, and more specifically, the left ventricle must overcome to pump that blood from the left ventricle out into the aorta, out into the system, out to the tissues. Okay? So afterload is the pressure that the heart must overcome in order to get blood out to the body. Mainly what afterload is the arterial diastolic blood pressure. So basically, our blood pressure. Think about it. If someone has hypertension, someone's coming into the ER, has a blood pressure of 220 over 110. I have seen that, I promise you. Think about how much more pressure that artery is exerting than someone's pressure who's 120 over 80, right? If someone who has so much pressure in their vessels, in their arteries, think about how much harder that left ventricle has to pump to get that blood out into that pressure. If I've got a closed door, right, because there's all this pressure behind the door and I am trying to push against that door, think about how much harder I have to work to get out of that chamber, as opposed to a door who's not shut that tightly. There's not that much pressure, and I can just quickly and easily go on out, right? The left ventricle has to push against whatever pressure is in the aorta. If there is a ton of pressure pathologically in the aorta and in the systemic circulation, the ventricle has to pump that much harder against it. Does that make sense? Okay, that's afterload. It's okay to have an increase in preload, an increase in volume. We just talked about how that might actually increase contractility and actually increase how well the ventricle contracts. Is it ever good to have increase in afterload? No. You don't ever want an increase in afterload because you're asking the left ventricle to work too hard. Anyone heard of enlargement of the heart or left ventricular hypertrophy? This is why left ventricular hypertrophy or enlargement of the heart happens. Because the left ventricle is just like any other muscle in the body. You overwork it, it's going to get bigger, right? Yes, we want our muscle, or we want our bicep to get bigger because of increased resistance. We don't ever want our left ventricular muscle to get bigger because of increased resistance. That's pathologic. That's setting the person up for heart failure. Okay? So increased afterload, never good. Increased preload, could be okay. Could be beneficial. Could increase the contractility of that ventricle contracting. Does that make any sense at all? Please? Okay, good. Here's another analogy for you. Excuse me? Bathtub? When thinking of preload and afterload in terms of a bathtub, you've got, here's your heart, here's the chamber, here's your bathtub, right? You've got the faucet, and you've got the drain. From the definitions that I just gave you, which analogy do you think the faucet is? Preload or afterload? Preload, right. Because it is supplying the volume of what you're filling up this chamber with. You're filling up the bathtub. So this is your preload, right? How about, well, obviously now, the drain is your afterload, right? It is the draining. It is the emptying of that chamber. If you've got a big old fat hair clog in your drain, I understand with long, thick, curly hair, how does that bathtub drain? Good? No. Sucks. Very slow. There's a lot of pressure that's sort of mounting behind that water to get that blood out of the tub and through that drain. So think of that as like an increase afterload, right? So you're filling it with the faucet, preload. You're draining it with the drain, afterload. And if you've got some sort of blockage or some sort of increased resistance in that drain, you're not going to be emptying the tub well. You're not going to be emptying that left ventricle well. Does that make sense? Okay. So changes in any one of these factors can certainly result in a change in stroke volume, right? All right. All right. One more thing can impact stroke volume, and then we'll stop there and we'll finish up next Monday with before we start talking about alterations. The other thing that it can impact stroke volume besides preload and afterload is myocardial contractility. So the actual ability for that muscle to contract. Myocardial contractility can be altered because of changes in preload. We just talked about that, right? Either too much blood filling that ventricle or not enough blood filling that ventricle can affect how well that ventricle snaps back during contraction. It can also be changed by inotropic agents. So I promise we'll be talking about this in the next couple of weeks in pharm. As I mentioned, we're sort of aligning our cardiac discussion. So you'll be talking about a family of cardiac drugs in pharm called inotropic agents. Anyone know what inotropic agents are at this point before you've actually gotten them in pharm? Mm-hmm. Right. They change the contractility of the heart. So you've got positive inotropes, which increase the contractility, or you've got negative inotropes that decrease the contractility. Anyone know some good examples, or some maybe perhaps most important examples of positive inotropes that maybe even occur naturally in the body? Epinephrine and norepinephrine. They actually increase the contractile abilities. They increase the contractility of the heart. Those are good examples, epinephrine and norepinephrine. And you'll talk about others in pharm. And then lastly, another factor that impacts myocardial contractility is obviously adequacy of the oxygen supply getting to the myocardium, right? If we've got this really crappy blood supply to the muscle of the left ventricle, think it's going to beat well? No, absolutely not. So these are the things that impact myocardial contractility. So, in summary, preload, volume, afterload, pressure, and contractility all interact with one another to determine someone's stroke volume, which, as we know, also plays a part in determining someone's cardiac output in the big picture. Any questions about that? Does this make a little bit of sense? Okay. It's going to make even more sense when we start applying it to patients and start talking about alterations next week. Good. We actually have a couple more minutes, so I'm going to keep moving here just a little bit. Okay. So that was our discussion regarding stroke volume and how stroke volume can ultimately get altered to ultimately impact cardiac output. But remember, there's another part of the equation to cardiac output, and that is heart rate. So let's talk about some things that impact heart rate. The cardiovascular sort of control center is the medulla in the brainstem. So our brain can certainly impact heart rate, as we sort of talked about already today. Another thing that can certainly impact our heart rate is neural reflexes. We have, as you know, sort of baroreceptors throughout our body that sort of sense when our blood pressure is low. What do baroreceptors do how do they what do they tell our heart rate to do if our blood pressure is low? If we're hypotensive or our blood pressure is low for other reasons, what does the baroreceptors do after they sense that the blood pressure is low? Yeah, why? Try to get that blood pressure up. Try to get blood going, if there's decreased blood pressure, that means basically there's probably decreased blood getting to our organs, right? So the baroreceptors try to increase heart rate to sort of compensate, to sort of get that blood circulating again and get that blood going back to the tissues, to the organs, to the kidneys, to the livers, whatever, to the livers. I think last time I checked we have one. Get that back to those organs, okay? There's also some receptors in the atrium that also sense volume, sense how much blood pressure is there, and then be able to sort of compensate by heart rate. And then obviously other things in our bodies like hormones and biochemicals like epinephrine and norepinephrine, et cetera, also can impact our heart rate. Epinephrine and norepinephrine, as we talked about in sort of our stress lecture, are catecholamines. That's the name of that particular chemical family, and they certainly do impact our heart rate as well. So again, things can certainly impact the heart rate, just as things can certainly impact our stroke volume. Again, increased heart rate will certainly increase our cardiac output for a while, but eventually, if you've got a super, super, super fast heart rate, it will eventually actually decrease someone's cardiac output because it allows for less time to fill and less time to get blood out. So I've seen people come into the ER for like dysrhythmias. One of them is SVT, supraventricular contractions, tachycardia. And what basically that is that they have like a heart rate, I kid you not, they're sitting in the stretcher and their heart rate is like 200. So think about it, right? Think about that poor little ventricle is boom, 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 boom. Is it allowing any time in between contractions when someone's heart is beating at 200 beats a minute? Is it allowing any time for diastolic filling? No. Therefore, are they getting any blood pumped out? No. So I've seen people with blood pressures or heart rates of like 200, but yet their blood pressure is in the toilet. I mean, I'm talking about systolic blood pressure of like 60, 70, 80. Lower than 80, 60s, 70s, because there just is no cardiac output with the ventricle contracting that fast. There's no time to fill that ventricle. Therefore, there's no blood getting pumped out of that ventricle when someone's heart is just beating like that, right? So again, increased heart rate for a while is good. Like when we're exercising, it's good for our heart rate to be at 120, 130, whatever it is. That's going to increase our cardiac output and allow us to better exercise, right? But you get to a point where increased heart rate is not healthy. It's not pathologically doing you any good. And then you start to see your cardiac output go in the toilet. Does that make sense? Okay. So diastolic phase is shortened when the heart rate is too high and it does not allow for any ventricular filling. Last but not least. Okay, we know what cardiac output is now. We know how the factors affect cardiac output. How do we clinically measure it? How do I look at my patient in this bed and know what your cardiac output is? Because I can pretty much guarantee I'm not going to be able to have all the numbers to do that little equation. How do we truly know how much blood is getting pumped out of someone's heart? Ejection fraction. It's measured via an echocardiogram, so you actually send someone in for like a radiographical study where they can actually visualize both the contraction of the heart and also measure how much blood is getting ejected out. So a normal ejection fraction of a person sitting here resting should be about 60 to 75%. A decrease in ejection fraction is, without a doubt, the hallmark of ventricular failure. I mean, that should just make sense to you. If you've got a decreased ejection fraction, that's telling you that the ventricle, for some reason, is not ejecting that blood properly. So anything really under 60 is an abnormal, sort of pathologic ejection fraction, and therefore telling you that they have a pathologic cardiac output. I've seen people with ejection fractions in the 30s, 40s. So pretty bad ventricular ejection going on there. So that's how we clinically measure cardiac output. Yes, we have the formula, but how do we actually clinically in the real world find it out? Ejection fraction. Okay? That was a lot of information. Didn't even make sense. Okay. Like I said, it will make more sense next week when we start to talk about alterations and what actually happens in heart failure, what actually happens in an MI. But we laid a really good foundation for that understanding next week. All right, and that is it. I hope you guys have a great short week. Have a wonderful Thanksgiving. Eat way too much. Wear your elastic pants. It's like that. Remember? Do you guys remember that? Old now. The Friends episode where Joey wears Phoebe's maternity pants to Thanksgiving dinner. It's actually a really good plan. I still have mine pretty fresh since I had the baby not too long ago. Maybe I'll slip those on Thursday. See you guys. Have a good week.